type 2 diabetes is a disease of insulin resistance. Not to say that there aren't other variables that are inputting here, but it is built on a foundation of insulin resistance. Let's look at insulin and then look at it through the lens of a cell itself. So here we have a cell, this big circle with an insulin receptor, so a door that only insulin can come and knock on. We have insulin receptors at every cell in the body, literally every cell, from bone cells to brain cells, from liver cells to lung cells. They all have insulin receptors. And because every cell has an insulin receptor, every cell responds to insulin, but the cells, of course, respond differently based on what the cell is and what its job is. So when insulin comes to an insulin receptor, that there is a cellular action. Now, to create an example of this, we have glucose. Some cells, like muscle, which I'll discuss in a moment, insulin will stimulate the uptake of glucose. So here we have glucose outside the cell, and now insulin allows the glucose to come in. Although, of course, insulin does much, much more throughout the body than just regulate glucose levels. But this is just an easy example. Now, this is when things are working right. However, based on certain insults to the cell, which I'll elaborate more on in a moment, we can have a cell that doesn't respond as well to insulin as it used to. So the action is compromised, or the cell has become insulin resistant. This could result in an increase in blood glucose, and it also is accompanied by an increase in insulin levels. But this is all what's happening when the cell has stopped responding as well to insulin. So what was once a polite knocking on the door of the insulin receptor now becomes a pounding as insulin is higher and more aggressive, if you will. And that is sufficient in some instances to restore the actions of insulin. But in the course of this definition, there are two things that I really want to emphasize. If insulin resistance is a coin, these are the two sides of that coin. One is the compromised insulin signaling itself. Some cells aren't responding as well as they used to the hormone insulin. And then second, the other side of the coin is that insulin levels are higher than they were before. We must understand or appreciate both of these sides of the coin that we call insulin resistance in order to understand how insulin resistance is so pivotal and fundamental to so many diseases. So with diabetes in mind, here we have an individual. Over the course of their life, they're becoming more and more diabetic. Or in other words, glucose levels are going up, because that is how we define diabetes clinically. It is based wholly on the glucose levels. Unfortunately, with this paradigm, what goes totally overlooked is insulin. And insulin is going to look something like this in the average diabetic. It starts low, and then it goes high. And then it's high for a while, and in some individuals, not all, in some individuals it starts to taper off. But there are two time points worth highlighting. This initial period of time is the period known as prediabetes or insulin resistance. Why this state is so often undiagnosed or overlooked is because glucose is normal in the state of insulin resistance and insulin is elevated. So insulin is the more sensitive or early marker, early indicator of progression on this pathway towards type 2 diabetes. And then as you see beyond that next hashed line, we now progress eventually into frank type 2 diabetes. This is a state defined by both elevated glucose and, yes, elevated insulin. Even though we say insulin becomes insufficient in some people, we say that, but insufficient is a relative term. It simply means there's not enough insulin to keep the glucose in check. That's true, but that is not to say that insulin has become itself low. It isn't. It is often still significantly higher, multiples higher than it was before in a normal, healthy, insulin-sensitive individual. This, nevertheless, is type 2 diabetes. But again, what I hope you take away from this is that our failure to measure insulin itself means we are failing to detect insulin resistance in its earliest stages. Here we have that same paradigm that I presented just a moment ago. Now let's superimpose on this paradigm specific cells. I strongly contend that insulin resistance starts in our fat cells. So the fat cell is the first tissue to fall. And so the fat cell being insulin resistant is really what's going on in this first phase of this progression. And then when we start to see the changes in glucose, this is likely occurring once the insulin resistance has progressed or spilled into 3 other tissues: muscle, liver, and pancreatic alpha cells. And I'll go into more detail there. The causes of insulin resistance, I believe there are 3 primary causes. One is chronically elevated insulin itself as a cause of insulin resistance. Second is stress, chronically elevated stress, or even acutely, and then acute or chronic inflammation. Stress is, of course, a state that is typified by these two prototypical stress hormones, cortisol and epinephrine. These are both known hormones to stimulate or to increase blood glucose levels. Because they are trying to push glucose up, they are accurately referred to as insulin antagonists, because insulin is trying to push it down. As these 2 stress hormones continue to push up, provide an upward pressure on the glucose levels, it just means insulin has to work harder and harder. Insulin resistance, in other words. Now, in the case of inflammation, when the body experiences higher than normal levels of cytokines, it doesn't have to reach a level of sepsis. They also create an insulin-resistant state. This is something that happens very acutely, and so insulin sensitivity starts to go down, and now we're, of course, moving ever closer towards full-on insulin resistance and diabetes. Now, with regards to the inflammation, I just wanted to highlight some of the primary inputs there. We have other environmental things, stimuli, like diesel exhaust particles and cigarette smoke. And then we have endogenous stimuli, like autoimmune disorders, for example. All of these are known to increase inflammation, which is then known to compromise insulin sensitivity. Now, to what I consider the biggest of these 3 variables, hyperinsulinemia. This might seem a little strange, but chronically elevated insulin results in a steady reduction in insulin sensitivity. I believe this represents what is actually a fundamental biological principle, namely that any incessant stimulus to a cell will result in a resistance to that stimulus, whether it is a hormone like insulin, and there are other examples, or whether it is a drug, or whether it is something like an antibiotic. The cells that are exposed to this stimulus become resistant to the stimulus. I strongly contend that hyperinsulinemia is one of them. Insulin resistance starts in the fat cells. So when the fat cells fall, the rest of the body isn't far behind. So let's take a moment and explore the origins of insulin resistance at the fat cell. As people, we may have 2 different individuals, 2 fellows who were roommates at university, and then they go on and get married, get desk jobs, and life settles down, if you will. As life settles down, the waistline starts to expand, and they're both gaining 10 pounds of fat per year, let's say, until they join each other for their 10-year reunion, and they're both morbidly obese. So in this case, these 2 men who appear to be gaining fat at the same rate could be gaining fat in different ways. And specifically, fat tissue expands either through hypertrophy or hyperplasia. In the case of hypertrophy, that, of course, is simply, and you all know this, this is when the individual cells themselves are getting bigger. There's no change in cell number. It's just the cell itself is expanding. In contrast with hyperplasia, it's when the cell number is changing. Cell size isn't much. This would be like fat cells that start to get a little big. Before they ever get too big, they simply recruit new fat cells to help carry the energetic burden of storing ever more fat. Hypertrophy of the fat cell is not a good thing. That is a bad thing, metabolically speaking. Hyperplasia of the fat cell is metabolically a good thing. Now, to highlight the role of insulin in this process itself, here's a study that what they found here is that when at the sites of insulin injection in type 1 or type 2 diabetics, the fat cells, the adipocytes, have hypertrophied several times over normal size, upwards, potentially 4 times or more. And at the whole body level, this can look something like this, where the reason, of course, we tell diabetics to rotate their injection sites is to prevent the insulin from inducing such obvious adipocyte hypertrophy, as we see here in these instances of consistent injection, either on the thighs in this woman or on the belly. When we have a fat cell becoming insulin resistant, and that is happening on the hypertrophic side. Insulin is always stimulating the uptake of fats from the blood. Specifically the intake of activations of lipoprotein lipase and pulling lipids off of the triglyceride-rich lipoproteins. So insulin is always stimulating the uptake of fats. Usually, however, insulin is inhibiting the breakdown. In other words, it's inhibiting lipolysis, and that's why I have this sign here. In the hyperplastic fat cells, they maintain their insulin sensitivity. So insulin can always tell the fat cells to store the energy. In contrast, the hypertrophic fat cell cannot store anymore. So insulin is force feeding the fat cell more and more fat, and insulin would attempt to tell the fat cell to not let any of it go. The hypertrophic fat cell doesn't listen. It is now leaking free fatty acids, even though insulin is trying to tell it not to. We forgive the hypertrophic fat cell because we would contend that that is its efforts to not get so big that it reaches an unhealthy or even a dangerous level that it cannot sustain its own size and becomes, say, necrotic or something like that. In the case of hyperplastic adipose tissue, the size of the fat cells enables healthy normal vascularization and healthy normal gas exchange. In contrast with significant hypertrophy of fat cells, the fat cells are becoming increasingly too distant from capillaries and they become hypoxic. In an effort to resolve that hypoxia, the fat cell is secreting cytokines, some of which will hopefully induce the production of new blood vessels like VEGF, or vascular endothelial growth factor. The consequence of this throughout the body is that now we have more cytokines flowing through the blood, increasing, albeit to a subclinical state, inflammation. So if we put all these ideas together, the hypertrophic fat cell is what's becoming insulin resistant. And in the process, it is leaking free fatty acids and it is leaking pro-inflammatory cytokines. This then is spilling into the tissues downstream of the fat. When the blood vessels are becoming insulin resistant, they've lost their dynamic nature where insulin is normally inducing vasodilation and now it cannot. And so the blood vessels are staying constricted when they should be dilated. This, of course, exacerbates hypertension. In the ovaries, the hyperinsulinemia and the insulin resistance in the body is inhibiting the enzyme aromatase, which is preventing these estrogen spikes that are necessary for ovulation, thereby preventing ovulation, and at the same time resulting in an excess release of androgens, causing some of the inconvenient, awkward physical manifestations that accompany PCOS. Now, when insulin resistance reaches the brain, that is thought to be a fundamental cause of Alzheimer's disease, or at least part of it, to the point that some refer to Alzheimer's disease as type 3 diabetes. That is to say, insulin resistance of the brain. When the liver becomes insulin resistant, its handling of fats, what it's making and storing, as well as what it is packaging and releasing in the form of VLDL and HDL metabolism is changed, driving dyslipidemia. When the muscle becomes insulin resistant, among other consequences, the muscle will start to become sarcopenic because of the loss of insulin protecting muscle proteins. And then lastly, on just a short list of examples, the kidneys are retaining too much uric acid and thus driving gout. What is it that is responsible for insulin resistance progressing to type 2 diabetes? And to understand that, I think we need to highlight what happens at the muscle, the liver, and the pancreas. Now let's go to the muscle first. The muscle matters because the muscle is the main consumer of glucose. When someone has eaten a mixed macronutrient meal and glucose levels have spiked, it's the muscle that steps in to save the day. The muscle will consume up to 80% of the postprandial glucose load. So the muscle plays a primary role in regulating blood glucose levels. The uptake of glucose into the muscle uses GLUT4, the glucose transporter 4. That is an insulin-dependent transporter. When the muscle has become insulin resistant, that process is compromised, and muscle glucose uptake can drop to half of what it normally is. Now, that's not difficult to see the problem. Muscle is the main consumer of glucose, and if its consumption is reduced, then blood glucose levels will be elevated. And indeed, that is an absolute contributor to the steady rise we see in glucose as someone is progressing towards type 2 diabetes. Now, if we look along the top, what we've done, I'll back that up, we have the person who's kind of right in the middle of insulin resistance, just about to start diabetes. Now we're pushing them into the diabetic realm. Now we're starting to see the glucose come up. The liver is, of course, absolutely central to nutrient metabolism at the level of the whole body. I want to highlight two processes involved in the liver with regards to nutrients, and that is the production of fats, lipogenesis, and the production of glycogen, or the stored glucose. Insulin in a normal insulin-sensitive liver will stimulate both of these. It's both driving the production of fat and the storage of glucose as glycogen. However, when the liver becomes insulin resistant, something interesting happens. Lipogenesis is unaffected. Insulin can still stimulate lipogenesis. However, glycogenesis is compromised. And now the liver that is supposed to be storing glucose as glycogen is now ignoring insulin's heat and is breaking down the glycogen. In other words, glycogenolysis has been activated, again, despite insulin's best efforts. And now the liver that is supposed to be storing glucose, lowering blood glucose levels, is releasing glucose, compounding this fight that the individual may be having with blood glucose levels. So the insulin-resistant liver is now directly contributing to the mounting diabetes. So we take this individual who is moving ever closer towards full-on type 2 diabetes. When the liver falls, we take a significant step into that territory. Within the pancreas, among the myriad cells, we have alpha cells and beta cells, each of them producing glucagon and insulin, respectively. These two are a yin and yang when it comes to blood glucose. Whereas glucagon is always attempting to increase glucose, insulin is, of course, always attempting to reduce glucose. Now, independent of this indirect battle they're having over glucose levels, they do have a direct effect. And specifically, insulin from the beta cells will directly inhibit glucagon release from the alpha cells. So insulin is sort of abusive in that sense to its alpha cell neighbor, and it is reducing the production of glucagon. And that would help insulin achieve its goal to lower blood glucose. However, the alpha cell can become insulin resistant. And now insulin's inhibitory efforts are lost. And so insulin's attempting to inhibit blood glucose levels by inhibiting glucagon, and it no longer works. Once again, we continue to take steps deeper and deeper into full-on type 2 diabetes. If insulin resistance is fundamental in its origins in the etiology of diabetes, how can we fight the insulin resistance? I strongly believe that the best way to focus on improving insulin resistance is to lower insulin itself. Now, you'll recall, of course, I emphasized what I consider three primary causes of insulin resistance: hyperinsulinemia, stress, and inflammation. And you would say, Ben, why aren't you focusing on the stress and the inflammation? It's because those two are harder to manipulate. Insulin, I believe, is not. I think that is something that is firmly in our control. So the best way to improve insulin sensitivity, I believe, is to lower insulin, and that is done by a mix of a whole bunch of things. I'll emphasize just dietary interventions and anti-diabetic drugs. On the good side, we have metformin, and we have anti-inflammatory medications like, for example, low-dose aspirin. Both of those work, and I consider them good because they do work, and the side effects are generally minimal. Metformin is the most widely used anti-diabetic drug in the world, and for good reason. It is effective with fewer side effects than normal. But as good as this best diabetic drug is, it is still only half as effective as even modest lifestyle strategies. We should never look at a drug to solve insulin resistance or type 2 diabetes, in my mind. Now, on the not so good side, I won't emphasize the SGLT2 inhibitors, although I simply only worry about them because of the consequences on the urinary tract, like infections and cancer risks. I want to highlight thiazolidinediones, or the TZDs, because they provide such an incredibly relevant example of the fat cell being at the center of insulin resistance. You'll recall that it's the hypertrophic adipocyte that becomes insulin resistant. Now, the magic of TZDs, the blessing and the curse, if you will, is that a TZD can take hypertrophic fat and convert it to hyperplastic fat. So we directly improve the insulin sensitivity at the fat cell and by extension, the rest of the body. But can you see the problem? When we basically give fat cells a limitless potential, a constant vacancy sign turned on, and the problem, of course, is that while we do improve insulin sensitivity, paradoxically, while we're improving metabolic health, we're making the patient ever more obese because we've basically given their fat cells that green light to move in more fat all the time. Now, lastly, we have insulin itself, whether it is, in fact, exogenous insulin through insulin therapy, or whether it's an insulin secretagogue like sulfonylureas. These are used because we look at diabetes, as I said, in a glucose-centric paradigm. The typical clinician will only have a regard for the glucose levels, and they will say, because glucose is all that matters, let's lower the glucose at any cost, including pushing the insulin up to potentially super physiological levels. The problem with this paradigm is that the true lethality or pathogenicity of diabetes is not based on the glucose. The true killers are really derivative of insulin. A study that was published that reviewed studies in type 2 diabetics looking at insulin therapy concluded, and I quote, "There is no significant evidence of long-term efficacy of insulin on any clinical outcome in type 2 diabetes. However, there is a trend to clinically harmful adverse events. Some of these adverse events are dramatic, including 2 times greater risk of cancer and 3 times greater risk of heart disease mortality." So when we give the type 2 diabetic insulin, we're making them fatter and sicker than they were before. And what do you think happens to insulin resistance? Given the role of hyperinsulinemia as a cause of insulin resistance, insulin therapy in a diabetic makes the insulin resistance worse. They have to give themselves ever higher doses of insulin as the body becomes ever more resistant to it. I think giving a type 2 diabetic insulin is similar to giving an alcoholic another glass of wine and hoping that will solve the problem. We are giving the person more of the very thing that's causing the problem. I want to highlight 3 typical low-fat, the conventional thinking, the dogmatic dietary advice, low-fat diets, low-carbohydrate diets, and intermittent fasting. This was a study that looked at a small cohort of people with type 2 diabetes who were on insulin therapy, and they each chose a different form of intermittent fasting. Within just weeks, their insulin sensitivity had improved so much that they were able to stop insulin therapy. In the case of a low-fat, or which is synonymous with high-carbohydrate diet, I want to highlight only one study done in the late 80s by Gerald Reaven, a legendary diabetes scientist. He took patients with type 2 diabetes and put them on a high-carbohydrate, low-fat diet that followed perfectly the recommendations of the American Diabetes Association. And he concluded, and I quote, "These results document that low-fat, high-carbohydrate diets containing moderate amounts of sucrose have deleterious metabolic effects when consumed by patients with diabetes." So we've known for 30 more plus years that the conventional dietary advice for diabetics may make the situation worse. Now, to highlight low-carbohydrate diets, I want to present data that has pitted the two against each other, low-fat versus low-carbohydrate. What happens to insulin when we eat these 3 macronutrients? When we eat fat, insulin won't change. When someone eats protein, there can be a modest or higher than modest effect on insulin. When someone eats carbohydrate, which in nature generally occurs as a pure carbohydrate, there can be a significant insulin effect, indeed 10 times higher than normal, and stay elevated for hours. Of course, not all carbohydrates are created equal. A piece of bread, for example, has a very different effect than, say, a serving of broccoli. Now, let's look at what happens in humans when they're put on 2 different diets. Only a significant reduction in the glucose on the low-carbohydrate diet group. We saw a modest reduction in insulin, 16%, on the low-fat diet, and then we saw a 50% reduction in insulin levels on the low-carbohydrate diet. We saw similar reductions where the low-carbohydrate diet had multiples greater improvements in insulin resistance than the low-fat diet did. Another study, Here are the average levels at baseline. What we found was insignificant changes in glucose in either diet. That's not too surprising. Those glucose levels are already pretty good. Insulin tended to go up on the low-fat group. It tended to go down in the low-carbohydrate group. And these differences became even more obvious with the measurement of insulin resistance, where the insulin resistance score started at 1.28. This is the HOMA score. It went up, meaning insulin resistance got worse in the low-fat group, and it went down, meaning insulin resistance got better in the low-carbohydrate group. Insulin in the insulin-resistant group was 16 microunits, and then it was 5 in the insulin-sensitive group. When both groups were put on a low-fat diet, there was an insignificant change. Insulin didn't really go anywhere. In contrast, on the low-carbohydrate diet, something interesting happened. The insulin-sensitive group didn't really experience any benefit. They're already insulin-sensitive, although importantly, both of these groups were controlled for body mass. So these were people of similar body weight. However, the insulin-resistant group had a significant reduction in insulin on a low-carbohydrate diet. I think there's something very relevant about these findings. But if you're insulin-resistant and you're trying to improve your metabolic health, clearly there's a winner here, and that would be the low-carbohydrate diet. Now, in conclusion, how might you or those around you, patients or loved ones, be able to determine whether they are insulin resistant? I think there are two strategies. The first one is to look at your fasting insulin. If the fasting insulin is less than 6 microunits per mil, or in picomoles it's less than around 40, that's a good sign. That's evidence that the person is insulin sensitive. However, insulin, like every hormone, has its own rhythm, and it's possible you'd get someone and you measure their insulin at a peak, and maybe they're in the low teens. And you would say, well, that's higher than Ben said, and that could be a problem. Well, if it's low teens, could still be good. All the more reason to look at the next measurement of insulin sensitivity, and that's the fasting lipids, the triglyceride to HDL ratio. If that dividend is less than 1.5, that's a very good sign that the person is insulin sensitive. If it's higher than 1.5, that's a warning that they likely are insulin resistant. In conclusion, I just want to emphasize the fact that we are all worried about type 2 diabetes, and rightly so, as it's increasing globally. We need to remember that type 2 diabetes is generally going to be, if not always, a consequence of a mounting insulin resistance. And it's the insulin resistance that I submit starts in the fat cell, and then it moves through the rest of the body as the first domino falls and tumbles into the subsequent domino.
In the fellow who has higher glucose levels and normal insulin, it could be a situation where he is experiencing stressful situations, or even something as seemingly benign as a bad night or two of sleep that would raise his glucose and not necessarily be pushing up the insulin at the same time. So in that sense, it might be something somewhat less dietary related. So more data is always better than less. And so my answer would be a very hearty yes. In some instances at 2 hours, insulin may be back to normal, frankly. And I would say if that has happened, then that is a wonderful sign. That person's very insulin sensitive. But if a person is able to get over 2 hours, a blood sample and an insulin measurement every 30 minutes, 0, 30, 60, 90, 120, the simplest way to look at that insulin curve is just to ask, is the highest point of that curve at 30 minutes? If it is, then that's a good thing. That's a good sign that person is insulin sensitive. If the peak of that curve over those 2 hours, measuring every 30 minutes, is anywhere except 30 minutes, then that's a problem. That means the person is less insulin sensitive than would be ideal. SGLT inhibitors have a role, without a doubt, to very effectively regulating blood pressure and glucose very rapidly. There's no question about that. I simply think if we are having someone take a drug that is trying to push the glucose from their body, why not just limit the glucose coming in the first place? If we're worried about the glucose in the middle, rather than artificially shoving it out of the body, let's just very practically address the glucose coming in. Insulin very, very strongly has a role in lipid handling at the level of the liver. Insulin is always promoting the formation of triglycerides that would be sent around in the triglyceride-rich VLDL and then LDL. And hyperinsulinemia reduces HDL. So in that sense, insulin is directly altering those two variables. And then there's just correlational evidence in humans to show that triglyceride to HDL ratio correlates very well with markers of insulin sensitivity, including the HOMA score and including data derived from hyperinsulinemic euglycemic clamps, which is a very good way of measuring insulin sensitivity. That ratio can't maintain its fidelity across all ethnicities. There was a study that highlighted that the triglyceride to HDL ratio is not as valuable in an African population. There is a growing body of evidence to suggest that there's a more broad lipid panel and lipoprotein analysis that is used that actually has a better predictive power than the triglyceride to HDL ratio alone. That's a growing area. There was a manuscript just published recently that touched on this. The theme of it is that blood lipids are a more and more reliable marker of insulin resistance.